I would love to talk to you about home birth versus hospital birth.
Mm,
What do you think about that? And from my perspective, I could be wrong, of course, but I just feel like, irrespective of how calm you're trying to be, in hospital, there is a feeling of being rushed,
mm.
right? Whereas if you're at home, there's just you,
Oh, yeah.
most likely your partner. You can have the perfect setup that you want, can go as per your birth plan. Whereas in hospital, sometimes it's not the case. You do prepare a birth plan, but how likely are you to end up having that birth plan executed, right?
Yeah, it depends. I mean, there is the reality. I'm going to say hands down, if you can choose a home birth, choose it. The reality is only midwives support home
Home birth.
births.
Yeah.
And you may want a midwife and you may want a home birth, but you don't get a midwife. And so your options are to do what's called a free birth, which has no medical support, which I don't. This is a hard part, right? In some ways, can you absolutely just do it by yourself? Yeah, I believe that. I do. The same way a cow can birth their calf by themselves at the farm.
Have you heard any stories of any client that you had that called you in active labor?
Yeah. I've delivered a baby because the midwife didn't make it in time. Not my role. Hopefully I won't get in trouble by my regulatory board. There was no choice. The midwife didn't make it. The baby was coming. I had done it watched many years before. I knew you can do it. I've had a mom deliver, the baby came so fast, both the midwife and the ambulance didn't make it.
Oh my
You
goodness.
can. You absolutely can. Do I recommend it as a medical professional? No. No, I do not.
Yeah.
Because unless you have your own medical knowledge and training, you may not know if things are not going well. And that's why the medical system exists, even though it may not be practiced as such. But it's to observe from the outside in case they're needed to prevent any bad situations. Or you may not know, for example, how much bleeding is normal bleeding postpartum.
Yes, yeah.
And there is some normal amount and there's some not normal amount, and you may not go to the hospital soon enough if left to your own devices. And so this is where, ideologically, I would love to be like free birth all the way. I would, because I do believe in our innate intuitive ability to birth. We would not be at 8 billion on this planet if we did not have this innate ability to do it. But as a medical professional who understands the bigger picture, I do think it's having eyes, even if we do nothing, having eyes to know when, if we need to intervene or transfer is very important. So if we have to have a hospital birth because we can't have a home birth, the best thing you can do is stay at home as long as possible. That is the best thing you can do, stay at home as long as possible. And hospital births, they don't always, I have some clients who actually say they feel better in a hospital because they know where they, if anything goes wrong, they're where they have to be. And that gives them comfort. And so even though I have that bias, hospital birth doesn't have to be a bad birth. And we can eliminate all the hospital feelings, but, feel at the hospital, but we can change a lot of it. And it mostly comes from here. So we can do a lot there. And my hope in the future, hope you're listening, government, build more birth centers. More birth centers. We don't have to make the birthing units at hospitals look like the rest of the hospital.
Yeah.
I think there are so many ways that we could have adjacent, literally adjacent. So yes, there's that little bit of travel to the OR maybe, but can even maybe be a separate building. I don't know if that's possible, but just we don't have to make them look this way.
Yeah.
And that takes, a conscious design to honor what this process is.
In hospital, do you think the care providers rush too quickly to intervene rather than trusting the process?
Depends on their experience. I'll say it like that. Sometimes I would say Yeah, often yes. Often yes, in the sense of augmentation is used a lot, induction is used a lot. Not, yeah, suggestions on even just, let's get the epidural going now, even if you're not in pain now. You might want, if I know you might want it later, well, the anesthesiologist is here now, so let's do it now. So there is that, yes, there is that level of rush, or, oh, we need to get these things, because they do. There's things they need to get done before their shift, before this, before that. So there is that sense of their agenda, their time management.
Yeah.
And maybe not as much as, like, I call it like doing the dance. Like, I did, if any of you do performances or improv work or things like that, back in the day, I was a dance major, you know, you find like there's this timing, you watch the stage and you see when's a natural time to join in, right? When it works versus, well, I want to walk in, so I'm going to walk in, right?
Yeah.
And so that's where that like midwife even approach is.
Yeah.
It is that you lead and we support versus in the hospital it's they lead. There is that dynamic for sure. Of course, nothing is black and white. I will say when I see and what can happen with more experienced or more comfortable doctors is that they do feel comfortable waiting more time. It goes both ways. It's either they assume they know too much and they're like, it's going to end up here, so let's just go. Or it is they truly like, there's some progress. Baby is good. We keep at it. There is some space for that. But it's how the practitioner themselves feel. And if maybe, not always, I don't like to generalize, so take this as a grain of salt. Maybe younger residents who are in the practice but maybe have not seen as much, maybe they're more nervous and they jump the gun a little bit more. And do doctors make wrong calls? Absolutely. They're human.
Do you think it could also be one of the results when there's a lot of pregnant women in the birthing center? And again, I know this is like just a spot on question I asked,
no,
but
for sure. I will say, if there's a lot of, like, for example, if there's a lot of people at triage, they'll actually turn people away if they're not truly in active labor. If someone comes in, they're kind of whatever, 2 centimeters, we can't take you. Absolutely not.
Okay.
They would rather do that than induce, because when I have 13 live rooms, you know, you get that.
Yeah.
There's 13 live rooms when you don't know how the babies are going to turn out, when they're going to show up, whatever. We're not going to add more chaos to that. So they are more likely to, it's called triaging, right? That process is who needs help the most urgent now. That's how they work. So are there sometimes times where they speed things up? Yes. But there's also sometimes when they slow things down because the broom over there, like, oh, we're going to turn down your Pitocin because we actually have 3 other C-sections that are about to go off right now and we don't have people to actually birth your baby. So we can't.
It's more about convenience, isn't it? It sounds terrible.
Yes, I would call it management. I would call it management. But convenience is convenient. Inductions are convenient. I will say that. It's convenient to induce a client when you know you're going to be there on that day. On that day in those hours. Not on the weekends, sure. Most doctors, there is something to be said about that, you know, especially when the Arrive trial, there's this big study that came out showing induction at 39 weeks is just as safe as induction at 41 weeks. So a lot of women who normally would have had the opportunity to go to 41 weeks, now doctors were saying, well, it's safe to induce at week 39, so let's go. Because, it is convenient.
Yeah.
We know when it's scheduled, we know when the patient's in, we have control, we know what's going on. Induction is safe. It is safe, but because it has risks, but it is generally safe, but it does have risks. But they don't ever talk about those risks. I find they always say, oh, it's all safe. And the downside to that, I find, is many cervixes are not very ripe at week 39.
Especially first-time moms, maybe?
Especially first-time moms. And so now we tripled the interventions.
But
Because
Dr. Olivia, you have been in the practice for almost 10 years
Yeah.
now, right?
Yeah.
And from your experience, like if you go back maybe 7, 8 years,
yeah.
inductions was not a common thing happening back then, right? Do you think like recently there's so much induction happening that it messes with the natural birth? Like even if it was gonna happen,
Yeah.
but they still just.
Okay, there's two parts to this.
Mm-hmm.
An induction labor is not the same as natural. Your own what's called spontaneous labor.
Right.
And I want to circle back a little bit to that ARRIVE trial because the study shows it's comparing apples to apples. Induction to induction, just at different times. It doesn't compare induction to spontaneous labor.
Mm-hmm.
So when everyone talks about, it's safe, well, it might not be more safe than spontaneous labor because that's not what they studied it against. So just aside there. But coming back, spontaneous labor and inductions are very different because the goal of induction is to get you to have 5 contractions in 10 minutes. Every 2 minutes, that's the goal of an induction. We want to get 5 and 10 is what they call it.
But what if the body is not ready?
Correct. Because, and this is the part that always will, in me, is, when your body's having contractions that close together every 2 minutes, transition, when you're 7, 8, 9 centimeters, right before you push. But when you start an induction, you're what? Hopefully 3 centimeters. That's the minimum that they should be starting Pitocin at. You don't have contractions usually every 2 minutes at 3 centimeters. So I use the analogy of induction is like jumping in the deep end right away versus spontaneous labor. You wade in from the shallow end and you get to the deep end.
Yeah.
Right before you're about to get out. Because transition is normally in a spontaneous labor a very short period of time. Goes right into pushing. But now you're expected to deal with the intensity of transition for the whole labor. That makes it very hard to do without an epidural. And now we have double interventions from one. And so this, our inductions happening more, they were always happening, but they were happening typically what we call 41 and 3 at the 41 mark plus 3 days. So you were given a lot longer for your body to be ready for them to say, we don't want to go past week 42. We'll schedule you now in case there's bump backs. And hopefully before week 42, you give birth. Now what I'm seeing is there's every medical reason in the world to induce before 40 weeks. That I'm seeing significantly more.
What could be the medical reasons?
Gestational diabetes is one of them. So there's a standard protocol. It could even be as early as 37, 38 weeks that they recommend induction because they don't want baby to get too big.
Hypertension?
Hypertension is another medical condition, but there's always, this is the thing, there's the condition and then there's your actual results. So someone who could say they're gestational diabetes positive, yes, but if they manage it with diet and lifestyle and all their blood sugar is okay and their baby's tracking well, why would we follow the algorithm of needing to be induced before week 40?
What is the time like for you?
Yeah.
What do you think is the healthy time to go till like 41
42.
weeks? 42 weeks.
No, that is the evidence. It's not just what I think.
Okay.
Up to week 42, 37 weeks to 42 weeks is considered a normal, just like normal time for moms to deliver their baby. We know week 37, our lungs are developed. It's safe to give baby. Week 36 quite often is often safe as well. So we know from there it's safe. From after week 42, this is where the odds, so trigger warning, I'm going to say the word stillbirth, right? So the odds of stillbirth go from being like 2% and under to almost as high as 12%. So there is something to be said of going too long, right? We keep the bun in the oven so long it burns. The placenta is not meant to last forever. So at some point it doesn't function as well because it's meant to degrade and leave, right? So having our babies past 42 weeks is ill-advised, but within the 37 to 42 weeks is perfectly safe.